The next thing that you must understand before you start ventilator training is resistance. What is resistance? As I told you, resistance is nothing but trans airway pressure. Resistance is a measurement of the frictional forces that must be overcome during breathing. So, these frictional forces are the result of the anatomical structure of the airway. So, the airways offer some resistance to the ventilator, and the air has to overcome that resistance so that it can go inside. And that is what is known as resistance. Now, during ventilation, there are various factors which determine resistance. The most is viscosity, density, endotracheal tube, or airway length. Now, the challenge is there are factors on which the resistance becomes dependent is given by an equation. The viscosity of the air doesn't change. So, once you are putting air into the lungs, whether it's an ARDS lung, whether it's a normal lung, the viscosity of the air doesn't change. Am I right? The density of the air doesn't change. The length of the endotracheal tube or the length of the trachea always remains constant. So the only factor which determines resistance is the diameter of the airway lumen. In certain cases, the trachea can be wider. In some patients, the trachea can be smaller. So the only thing that changes is the lumen of the trachea, not the length. So what we must understand that resistance is only dependent on the tracheal lumen. And why is it important? It is important because if you put a small size endotracheal tube, your resistance will always be higher. And that is why for resistance, it's very, very important to overcome resistance that you have a largest size endotracheal tube that you can easily insert into the trachea once you are putting a patient on ventilator. Similarly, the resistance depends on other factors like bronchospasm, secretions, endotracheal tube kinking, mucosal edema, all these factors which can increase the resistance or which cause obstruction in the airway will increase the resistance. So this is the formula for resistance as I was telling you for the compliance. Resistance is PIP, which is the peak inspiratory pressure. What is peak inspiratory pressure? It is the pressure in the airway. Minus P plateau. P plateau is the pressure at the alveoli divided by the flow in second. So let's assume, and these all numbers are given on the ventilator. If you have a PIP of 40 and a P plat of 25, then your resistance is 15. So the normal resistance of an unintubated patient is about 0.6 to 2.4 centimeter of water per liter per second. So in intubated patients, approximately 6 or higher is detrimental. So we don't want the resistance to go beyond 6, but then this needs to be calculated. And that's why it's important that the ventilator gives you a lot of information, but to analyze that information, to gather that information, you have to know how to calculate these numbers and act accordingly. Why is resistance important? Because in COPDs and asthma, your ventilator strategy will be completely different if the resistance is high. So the take-home point 3, put the largest size endotracheal tube to have least airway resistance. We know now that the resistance is dependent only on the lumen of the endotracheal tube and the airway. So largest size tube, and keep a very close watch on bronchospasm, secretions, mucus plug, and high airway alarms. A little bit about next thing in ventilation, which is PEEP. What is PEEP? PEEP is positive end expiratory pressure. Positive means you have maintained a positive pressure in the lung. End expiration means at the end of expiration. And pressure obviously means a pressure. So PEEP is a pressure that we leave at the end of the expiration in the lungs so that the alveoli do not collapse. Why is it important? What happens in inspiration? In inspiration, the alveoli open up. What happens in the expiration? They collapse. Open, collapse, open, collapse. Now what happens? If the PEEP is 0, every time the alveoli collapses, the oxygenation will go down because the oxygenation suffers. But what if I maintain a positive pressure at the end of expiration? So what the lungs will look like? Inspiration, expiration. So some pressure is maintained at the end of expiration, and that is why the hypoxemia or oxygenation can be better maintained if you apply a PEEP. So rather than this, it becomes this. So there's some pressure at the end of expiration. Then that is why every patient on ventilator is given a physiological PEEP of 5. And as soon as the disease progresses, we keep on increasing or decreasing the PEEP depending on the oxygenation. So through a diagram, I can again explain you. This is how the gas is going. And we have a gray area which shows inspiration. And if we apply a PEEP, the alveoli does not close completely, and it stays open even at the end of expiration and maintains the oxygenation. And that is why this is known as positive and expiratory pressure, and it improves the oxygenation. So I'll show you again. If you put up a PEEP of 10 on the left side, you can see the diagram. The lungs are expanded better, the alveoli remain always open, and the oxygenation is much better rather than when you do not apply any PEEP. So that is why it's very important to understand this concept when the patient's on ventilator. Another term which is known as the peak pressure. I had told you when we are doing this slide a few minutes back on resistance. Resistance is PIP minus P plateau. What is PIP? PIP is peak inspiratory pressure or peak airway pressure or peak pressure. It is the pressure which is recorded at the end of inspiration. So suppose you are ventilating a patient and the inspiration is 3 seconds. At the end of inspiration, there is a pressure which is shown on the ventilator, which is known as the peak pressure. Another is the plateau pressure. What is plateau pressure? The plateau pressure is measured after a breath has been delivered and before exhalation begins. What happens is we actually stop the ventilator for a brief period. Exhalation is prevented by the ventilator for a brief moment of 0.5 to 1 second. So we put a pause. So air go, as soon as we start the ventilator, the tidal volume goes up, inspiration ends. We give a small pause of 0.5 second and measure a pressure at the end of the alveoli. And that pressure, which is measured at the end of the alveoli, is known as plateau pressure. So if the lung is normal, the plateau pressure will be low. If the lung is damaged or there's a pneumonia or ARDS or suddenly the lung becomes bad, the plateau pressure will go up. So this is very, very important. These two are the most important pressures which you must understand before you start patients on ventilator. So this is a graph which represents it's a very common graph appearing on the ventilator. As you can see at the top, I have shown is a PIP. This is how the aspiration is starting. You can see on the graph, you start with a PEEP of 10. Then there's an inspiration happening. And at this peak, the inspiration ends. This is known as peak inspiratory pressure. After that, we give a small pause, as you can see, of 0.5 to 1 second. During the pause, since the air has already reached the alveoli, we measure this pressure, and this is known as plateau pressure. After that, this downward trend of the graph shows the expiration, and then the next cycle starts. So this graph is a very, very important graph which shows both airway pressures as PIP, and it also shows the lung pressure in the form of plateau pressure. These you must have in your mind always. In every few hours, you should have a look at these pressures when you are ventilating the patients. The other variable which you must understand is trigger. What is trigger? Trigger is in a common language, Indian language, is something which initiates. So we can say my anger gets triggered by if I don't see people working to their potential. It's a trigger. Some patients, asthma gets triggered by pollen grains. So ventilator also needs a trigger. How does ventilator sense that it has to deliver a tidal volume? So we have a button of trigger available on the ventilator. So the patient breathes a little bit. The ventilator senses now that I need to deliver the tidal volume, and after that the ventilation starts or the inspiration starts. So trigger is a negative deflection or a negative opening pressure like this. So if the patient breathes a little bit, the ventilator delivers the tidal volume. So this is known as inspiratory trigger, and another very important component when you are managing. So you have to set a trigger. The trigger for every patient is different. This setting of trigger determines the pressure or flow change that is required to start the inspiration. So we set two kinds of trigger. One is a pressure trigger, usually set at about -1 centimeter of water, and the other is a flow trigger, which is usually set at around 2 liters per minute. So you can set both triggers, but the trigger has to be set by the physician himself, may differentiate for every patient. The other thing which is important is pressure time product. This is a very innovative thing in ventilation. Few ventilators have started showing this, which is the average inspiratory pressure multiplied by the duration of inspiration. So suppose you have a patient where you have set at 15 breaths per minute. So pressure time product is pressure. So those 15 breaths, they will have a pressure, average pressure. As I told you, to deliver a breath, a pressure needs to be generated, isn't it? So it calculates the average pressure and multiplies by the duration of inspiration, and that is known as the pressure time product. The other important thing that you need to know in ventilator is P.1. What is P.1? So we occlude the airway. Let's say we block the endotracheal tube, and patient suddenly we tell the patient to breathe inside. This is a weaning criteria. When you are trying to remove the patient from the ventilator, P.1 becomes important. So we actually ask patient to breathe against the occluded airway, and we assess the ventilatory drive. A P.1 gives us a very, very important indication whether the patient is ready, whether the muscles of the patient are ready for weaning or not. And if they're not ready, we do not start removal of the ventilator. So P.1 is another pressure that one must be aware of before you start ventilating. This is how the triggers looks like on a graph. You can see a negative deflection, and then the patient, the ventilator delivers the tidal volume.